Hello everyone. Today I'm back with another obstetrics case. This is a case study on secondary postpartum hemorrhage, which is also known as excessive bleeding after labor. Usually there is two types of postpartum hemorrhage, primary and secondary. The only difference is the duration. Primary postpartum hemorrhage is seen within 24 hours of labor, while secondary postpartum hemorrhage is seen within 24 hours to 6 weeks after labor. Let's learn in detail about secondary postpartum hemorrhage through a case. Our patient is a 32-year-old woman. She's brought into the delivery suite by ambulance 6 days following a vaginal delivery at 39 weeks gestation. The pregnancy and labor had been unremarkable and the placenta was delivered by controlled cord traction. Following delivery, the woman had been discharged home after 6 hours. She reported that the lochia had been heavy for the first 2 days. Lochia is also known as vaginal discharge that is seen after birth. It contains a mixture of blood, mucus, and uterine tissue. It is usually seen within 4 to 8 weeks after childbirth. So, this patient had a heavy lochia for the first 2 days and then it settled to less than a period. However, she suddenly felt crampy, abdominal pain with a gush of fluid, followed by very heavy bleeding. She also passed large clots, which she claimed to be the size of her fist. She also gets dizzy when she stands up and she is nauseated. So the dizziness when she stands up could be postural hypotension. Upon further examination, she is pale with cool and clammy extremities. She is also drowsy. Her blood pressure is 105 by 50 mmHg and heart rate is 112 per minute. Upon examination, we can see that the patient is pale and she is cool and she has clammy extremities, which might point towards a loss of blood or hypovolemia. She also has a low blood pressure, hypotension, which might be the reason as to why she had postural hypotension. On abdominal palpation, there is minimal tenderness, but the uterus is palpable approximately 6 centimeter above the symphysis pubis. So there is minimal tenderness seen in the uterus. Speculum examination reveals large blood clots in the vagina. When these are removed, the cervix is seen to be open. Usually there is two conditions that the cervix is observed in. It is either seen to be closed or it is open. In normal females, when they are not pregnant or they have not undergone pregnancy, the cervix is usually closed. That is, it contains a mucus plug which is thick and it does not allow entry to the uterus. When a woman is undergoing childbirth during pregnancy, during labor, the mucus plug becomes thin, it's dissolved to facilitate the fetus through the cervical canal. So the cervix usually dilates to approximately 10 centimeter and the mucus plug is dissolved and it becomes thin. After childbirth, after the labor has been done, the cervix closes or returns back to its normal position after some time, like 4 to 8 weeks. It takes time and then it's closed. But in this patient, the cervix is seen to be open, which might indicate that there is retained products in the uterus. Proper evacuation of retained products might not have been performed after the delivery of the patient, so that is why the cervix might be seen as open. So the diagnosis is secondary postpartum hemorrhage because this does not occur in this patient within 24 hours. If it would have occurred within 24 hours, it would be known as primary postpartum hemorrhage. This patient has secondary postpartum hemorrhage. It is defined as the loss of more than 500 ml of blood vaginally following delivery. Primary postpartum hemorrhage is within 24 hours, as we have mentioned earlier. And secondary postpartum hemorrhage occurs between 24 hours and 6 weeks following delivery. There are some common causes of postpartum hemorrhage. Retained placental tissue, as I mentioned earlier, there might be retained tissues in the uterus of the patient, which could have resulted in the open cervix and excessive bleeding. Bleeding due to vaginal trauma, any trauma or injury caused to the vagina might also cause excessive bleeding in the patient. And endometrial infection, any infection caused due to either chlamydia or staphylococcus could also cause postpartum hemorrhage. To see if the patient has an endometrial infection or not, the lochia that I mentioned earlier, which is vaginal discharge after birth, it is either green or it has a different odor to it. So if the patient is suffering from a bad odor from the lochia, or if it is green in color, the patient should inform the physician and the patient should be checked for infection. Coagulopathy is also a common cause of postpartum hemorrhage. Coagulopathy is the abnormality in formation of clots in the blood. So this causes excessive bleeding in the patient. And uterine atony. Atony refers to the impairment in the uterine muscles or the inability of uterine muscles to contract. So when uterine muscles contract, they cause vasoconstriction, which results in reduced bleeding. But if a patient if a patient is suffering from uterine atony, that is inability of the uterine muscles to contract, it would lead to excessive bleeding and could be a common cause of postpartum hemorrhage. So what exactly is secondary postpartum hemorrhage? As I mentioned earlier, it occurs between 24 hours and 6 weeks postpartum. It is excessive bleeding seen after labor and delivery. Signs and symptoms that is usually seen is an increased heart rate, as this patient is also suffering from an increased heart rate, feeling faint upon standing, that is postural hypotension, and an increased breathing rate. It occurs more commonly in those who already have a low amount of red blood or are Asian, have a larger fetus, are obese, or are older than 40 years of age. These are the risk factors for secondary postpartum hemorrhage. How to treat this condition? Common treatment includes intravenous fluids due to excessive blood loss. We need intravenous fluids along with blood transfusions. And for medications, ergotamine is used to cause uterine contraction, which would result in vasoconstriction and thus reduce bleeding. Efforts to compress the uterus using the hands may be effective if other treatments do not work. Uterine massage is a simple first line treatment as it helps the uterus to contract to reduce bleeding by massaging the area, the lower abdomen. It could help in removal of the retained products and would also help in reducing the bleeding in the patient. Management and intervention. First, to immediately manage this condition, this woman is in hypovolemic shock and needs immediate resuscitation. Hypovolemia is the reduction in the blood volume, which results in hypotension. So this needs to be managed. Two white bore cannulae should be inserted and blood sent for full blood count, urea and electrolytes. Clotting and cross-match of 4 units with further red cells. Platelets or fresh frozen plasma requested depending on further evaluation and blood results. So based on the blood results, platelet or fresh frozen plasma should be requested and administered to this patient. Immediate intravenous fluid should be administered, usually colloid as volume expansion to maintain cardiac output. The uterus should be rubbed suprapubically, and if this fails, then bimanually, pending administration of 500 microgram ergometrin and commencing a syntocinon infusion. These measures the blood loss and aid immediate resuscitation while the diagnosis is investigated. As I mentioned earlier, the first line treatment usually given to such patients is a uterus massage, which helps in evacuation of the retained products or removal of the retained tissue in the uterus. And if it fails, we can further administer 500 microgram ergometrin, which would cause vasodilation in the uterine blood vessels, thus reducing excessive bleeding. A urinary catheter should be inserted to allow close fluid balance monitoring and renal function. And the anesthetist and senior obstetrician should be called. After the immediate management is performed, the subsequent management required in this patient. Firstly, the fact that the cervix is open is pathognomic of retained tissue and evacuation of retained products of conception should be performed. In the view of hemodynamic instability, general anesthetic is preferred. Intravenous antibiotics should be given as infection could also be a cause. And even if it is not the underlying cause of this condition, after the evacuation of retained products, antibiotics preferred to prevent any infection. The woman should be monitored initially in a high dependency setting until clinically and hematologically stable. And she's likely to have had a coagulopathy at admission, but she's still at high risk of venous thromboembolism as she's probably septic postpartum and has undergone anesthetic. So thromboembolic stockings and heparin should therefore be administered post-operatively. And an ultrasound scan would not be indicated in this scenario because we saw an open cervix, it implied retained products, and it would therefore be superfluous. Second, an examination under anesthetic is warranted anyway to establish any other cause of bleeding, such as vaginal or perineal trauma. And third, retained products may be confused with blood clot on postpartum ultrasound, so it is usually not preferred in this condition. That's it for today's session. Thank you for watching and please share this video. Thank you.